All right, I'm going to get it started, even though nobody's in here yet. I'm a little early. So, this is the live review. So, I guess I'll wait till one person gets there. We go. At least one person joined. Okay. So, I went through the Leik. Hey, girlfriend. So, I went through the book, this book, of course, and I went through the back to basically label all the questions. So when we are working on one section, for example, peds or whatever, like all of these questions, I went through it in the back, and this light is kind of. I went through it in the back, and I kind of like label it as cardio, pulmonary, or peds or whatever it was. I went through every question, so I could come up with a Pete's review. So I came up with a Pete's review. So I don't know if you have a Lee Bue EU Lee BU. Am I messing it up? Because I'm just gonna call you Miss Impress if I'm messing your first name up. Le B BU BA. I'm just gonna call you Miss Impress. I don't want to be messing up your name. So what I did was I came up with a piece review. So I don't know if I'm sure you guys probably have a pen and a paper right now. So I want to give you so you don't have to go through this. Um, so you don't have to go through the troubles that I went through. It took me a couple days to actually go through it's 700 and like 100 720 questions. So um I went through and I wrote any question with a patient under 18 years old, like 17 and under, newborn to 17. So those are all these questions, and I wanted to um we should be answering like 100 questions a week, whether it's from any any review book or any um, online source or whatever, anywhere that is questions or whatnot, we should be asking 100, answering 100 questions a week. So I got a 107 Pete's question in the back of the Leaks book. So I went through the trouble of marking them all so you can go ahead and do a Pete's final exam after this is our last one on Pete's. So do a final exam, whatever you want to call it. So I'm going to go ahead and real fast say what question it is in the back of the book. So real quick, it is, I'm going to say it fast. So just write it down. Here we go. 31, 32, 41, 43, 46, 56, 62, 66, 72, 74, 91, 101, 115, 124, 125, 133, 144, 159, 163, 173, 174, 175, 182, 185, 197, 202, 205, 213, 222, 224, 228, 230, 236, 240, 250, 254, 255, 258, 264, 265, 266, 275, 283, 285, 291, 293, 296, 301, 319, 329, 32, excuse me, 332, 339, 346, 351, 353, 359, 360, 362, 368, 371, 377, 384, 386, 387, 389, 400, 402, 417, 429, 439, excuse me, 429, 432, 441, 442, 444, 445, 447, 456, 457, 463, 470, 478, 479, 482, 491, 493, 503, 512, 530, 547, 565, 566, 569, 595, 690, 610, 632, 633, 634, 635, 636, 637, 638, 644, 645, 654, 657, 662, 668. And those are the PEDS questions in the back of the Leik's book. All PEDS, all the PEDS questions. So you can do a final exam on that. So once again, so I just read the list of the, you can't, yeah, I just read the list that I made. Sorry, that's coffee. Of the PEDS question in the back of the Leik's book. So you can do a Leik's final review. Okay, so I did not get a chance to read the adolescent chapter. Uh, so hopefully someone in the group have some PEDS questions. Just let me know in the chat box. You're welcome. Um, in the chat box if you have any questions. I mean, any came up with any questions. Um, the newborn chapter was pretty long. Not that long, but it was a little lengthy or whatever. So I didn't get to make up my own questions. So I did grab the questions from the back of the book. And like I said, I did not get to the adolescents. So maybe Miss Impress, you got some questions that you want to ask or whatnot. If not, like I said before, I will always have at least 10 questions for the study group. Um, and I have 11. So with that being said, let's just get to the questions. It's just me and you, boo. So I hope you've been reading and studying. So here we go. Let's see. Let me see. 115. So here we go. When evaluating the blood pressure on both the arms and the legs of an infant who has diagnosis of K, how do you pronounce this word? I'm sorry. Hold on. Because I don't want to mess the word up just like I don't want to mess nobody's names up. And I code ARTKARC TA. Here we go. Pronunciation. Oh, okay. Do you have the book? Oh, you're not even in the program yet? Coarctation. So, when evaluating the blood pressure on both the arms and the legs of an infant who has diagnosis of coarctation of the aorta, which of the following is correct finding? is the correct finding? Is it A, the blood pressure is higher in the arms than in the legs? Is it B, only the diastolic blood pressure is higher in the legs than in the arms? Or is it C, the blood pressure is higher in the legs than the arms? Or D, the blood pressure is lower in both arms than in the legs? So we are talking about coarctation. And so it's it is let me exactly read exactly what it is. And I didn't have time. I wanted to go ahead and put the page number also on here, but if I didn't have the time to do so. So I had clinicals today, and then I had to get my son from school, then I had to get dinner. Okay. So, coarctation of the aorta is a congenital narrowing of a portion of the aorta. It's usually located in the aortic area that is distal to the subclavian artery. Newborn may be asymptomatic if mild case or patent ductus arteriosus PDA. Period. Severe case will have heart failure or shock when PDA closes. Up to 30% of infants with this condition have Turner's syndrome. Female infants should get tested with karyotype analysis. Turner syndrome. So I like to continue to educate. I think I know what it is, but I want to make sure. Turner syndrome. What's this? Okay. A chromosomal disorder in which a female is born with only one X chromosome. So the symptoms include short stature, delayed puberty, infertility, heart defects, and certain learning disabilities. So once again, the way you want to check it is you compare the brachial pulses simultaneously, and you get the pressure, and then you get the um, sorry, excuse me. You compare the femoral and brachial pulses simultaneously. So the pulses should be the answer to that question. We never got the answer. Anybody, do you know the answer, Miss Impress? 5 seconds, and then I'll just say what the answer is. When evaluating the blood pressure on both the arms and the legs of an infant who is diagnosed with KR, coarctation of the aorta, which of the following is a correct finding? The blood pressure is higher in the legs than the arms. Okay, and let's go to the rationale. In the extremities. Uh, the blood pressure is higher in the legs than in the arms. Yeah. And the rationale for that, the blood is, oh, wait a minute. I'm sorry, I read it wrong. It's A, the blood pressure is higher in the arms than in the legs. It's higher in the arms than in the legs. So the blood pressure is higher in the arms than in the legs. In coarctation of the artery, aorta, blood pressure is higher in the arms than in the legs due to the narrowing in the aorta. Blood pressure must rise to get adequate blood flow to the lower extremities. Therefore, the blood pressure above the coarctation rises to compensate for this. Okay. The blood pressure rises. Blood pressure must rise to get adequate blood flow to the lower extremities. Okay. So with this condition, the blood pressure is higher in the arms than in the legs. All right, moving on. Let's see, 144. Here we go. While checking the red reflex on a 3-year-old boy during a well child visit, the nurse practitioner notes a white reflection on the child's left pupil. Which of the following conditions should be ruled out? So I didn't cheat or anything. Hi. I didn't cheat or anything, so I don't know the answers to all these either. So it's just like somebody just made up questions because I don't know the answers. So the red reflex on a 3-year-old boy during a well child visit, the nurse practitioner notes a white reflex on the child's left pupil. Which of the following conditions should be ruled out? Unilateral strabismus, unilateral cataracts, retinoblastoma of the left eye, color blindness of the left eye. So I don't know the answer to that. So I would just um, have to go and read about it. So let's see the red eye reflex, and that is on page 've seen it. Okay, it's on page 397. So let's see here. I read something about the white. I know it's not normal. I don't know what exactly it is diagnosed as. So let's see. Screening test for cataracts and retinoblastoma abnormal if there is a white colored. There we go. And it's cataracts. Okay. Determine the presence of white reflex. Rule out ret- ret- retinoblastoma and refer infant to pediatric eye doctor as soon as possible. So, what was the question again? You don't want to rule out cataracts. What number is this? Is a different question. 144. So is it B, unilateral cataracts, While checking for the red reflex on a 3-year-old boy during a well checked visit, the nurse practitioner notes a white reflection on the child's left pupil. Which of the following conditions should be ruled out? Oh, rule out C, retinoblastoma of the left eye. It clearly says that on page 397 that you want to rule that out. So let's see if it's right. Or the first one. Let's see. C, 144. You say A. Oh, you said it. Oh, you said the same thing. Yeah. Let's see. 144. See, I need to have these. Yep, we're right. Retinoblastoma is a congenital tumor of the retina. It usually affects only one eye, rarely both eyes are involved. During infancy, the tumor is a small size and it continues to grow with the child. This rare cancer is diagnosed by not noting a pupil that appears white or has white spots on it. One or both eyes may be affected. It is often first noted in photographs because a white glow is present in the eye instead of the usual red eye that results from the flash. Wow. So when you're taking photos, you'll see it, the white. Okay. Well, there we go. We got that right. So the third question, 159. So, okay, the red reflex examination is used to screen for, is it used to screen for cataracts and retinoblastoma? Let me see what is, because that's a different question. I just went to it and it said the red eye is used to screen for a screening test for cataracts and retinoblastoma. All right. So that was another. The red reflex examination is used to screen for cataracts, strabisma. I hope I'm saying that right. Blindness and blinking response, and it's cataracts in this because it's the only option. But I do know, so it's used to screen for both of them, cataracts and retinoblastoma. Retinoblastoma. All right, on to the next. I will never forget these questions. So just me going over it with you guys or with you, Miss Impressed, because I think you're the only one in here. Let's see, 159. Okay. The mother of a 4-week-old infant is concerned that her infant eyes are crossed for a few seconds occasionally. The nurse practitioner would A, recommend referral to a pediatric ophthalmologist, and B, advise the mother that this is a normal finding in infants up to 2 months of age. C, recommend that multivitamin supplements be given to the infant daily. Educate the mother on how to patch the infant's eye every 4 hours. So I'll go over it. I'll read it again to give you a chance to see if you want to answer or not. The mother of a 4-week-old infant is concerned that her infant's eyes are crossed for a few seconds occasionally. The nurse practitioner would A, recommend a referral to a pediatric eye doctor, B, advise the mother that this is a normal finding in infants up to 2 months of age, C, recommend that multivitamin supplements be given to the infant daily. D, educate the mother on how to patch the infant's eye every 4 hours. Okay. I am going with I don't think at 4 weeks that the child should go see an eye doctor, because for a couple seconds her eyes are crossed for a couple seconds occasionally. So I don't think it's a need for any type of treatment. I wouldn't recommend at 4 weeks. Advise the mother that this is a normal finding in infants up to 2 months. Um, B would be my answer, because a lot of kids, when they're looking around, because they really can't see nothing, so their eyes just like go everywhere, and it's only for a couple seconds. C, recommend a multivitamin. I don't know what a multivitamin is going to do with the cross-eyed. I never heard that that is a treatment for cross-eye. I don't know though. Educate the mother on how to patch the infant's eye every 4 hours. I haven't. Maybe that's a treatment when a child gets older, but I don't. Like I said, I don't think any treatment is necessary at 4 weeks when a child really can't see, so their eyes is just going all types of ways anyway. So let's see. Cross-eyed. Okay, page 397. Esotropia is what it's called. Misalignment of one or both eyes, cross-eyed. Infants younger than 20 weeks may have intermediate esotropia, cross-eyed, which usually resolves spontaneously. Some infants with obvious epicanthal folds appear cross-eyed. Refer to pediatrician, eye doctor if in doubt. Oh, yeah. Yeah, 2 weeks. So I still like to read the rationale also. So let's read the rationale. One, which one was that? 159? 159. Let's read the rationale. So wait a minute. Miss Impress, are you not enrolled in the program yet and you're just getting an early start, like a very smart individual with studying? Or what's going on? I think we talked about this before. Let's see. 159. 159. Okay. Advise the mother that the correct answer is B. Advise the mother that this is a normal finding in infants up to 2 months of age. Infants' eyes commonly cross over at times, and this is normal. This is a normal finding up to 2 months of age. All right. So, next question. Smart girl. When you graduate, Capella again? One. Here we go. The next question, number 4. Which of the following statements is false, false regarding physiological jaundice in newborns? Which of the following statements is false regarding physiological jaundice in newborns? A, physiological jaundice is the most common type of jaundice in infants. Remember, false. No date yet. Start December. That's what's up. B, The level of unconjugated bilirubin is increased in the newborn's body. Remember, we're looking for the false answer. C, phototherapy is usually indicated for these infants. D, it starts on the second to fourth day of life. Which of the following statements is false regarding physiological jaundice in newborns? A, physiological jaundice is the most common type of jaundice in infants. B, the level of unconjugated bilirubin is increased in the newborn's body. C, phototherapy is usually indicated for these infants. And D, it starts on the second to fourth day of life. So, 5 seconds for a response. 2, 1, 2, 3, 4, 5. Okay, well, let's read it. Jaundice. Jaundice. This way. D. Let's see what D is. Remember the false. Which one is false? It starts on the second to fourth day of life. Jaundice. So you're saying jaundice starts on the second. That's not true. That jaundice starts on the second to fourth day of life. Here we go. Not just any jaundice, but physiological jaundice. So here we go. Let's see. You sticking with D? Is D your final answer? Next time I'll mark the pages because I don't take up too much time to be flipping through the pages. Okay. I just read it. Oh, here it is. So here we go. Jaundice. Jaundice at birth or within first day of life, usually due to hemolysis or bleeding in utero. I know I'm messing that word up. utero, utero, something like that. So jaundice at birth or within first day of life, usually due to hemolysis or bleeding. Infant's color is bright yellow, or the soles of the feet are yellow. That's regular jaundice. Jaundice of full-term infant after 2 weeks of age. Bilirubin levels increases to rapidly greater than 0.2 milligrams per deciliter per hour, or is too high. Total bilirubin levels greater than 13 to 15. All right, you still got time to put the right answer. Let me give you the options again. Which of the following statements are false regarding physiological jaundice in newborns? Physiological jaundice is the most common type of jaundice in infants. That's A. B. The level of unconjugated bilirubin is increased in the newborn's body. C. Phototherapy is usually indicated for these infants. And D. It starts on the second to fourth day of life. So you have time to put your answer in there because I'm going to read it. Okay. Physiological jaundice, also known as neonatal unconjugated hyperbilirubin anemia, and neonatal, come on now with these words, ICTERUS, icterus, Jaundice first appears on the head and face. Is yellow. Sclera is yellow, the eyes, and progresses downward to the chest, abdomen, legs, and soles of the feet. So it goes this way and it doesn't miss the eyes. The whole body is what can turn yellow. Jaundice appears when bilirubin level is 5 milligrams a deciliter or higher. Physiological jaundice starts after 24 hours and usually clears up within 2 to 3 weeks. The total bilirubin levels in Caucasians and African American infants can peak at 7 to 9 milligrams per deciliter, but Asian infants have higher peak values, 10 to 14. So my son had I may as well read this. Onset is later than physiological jaundice for breast milk jaundice. Breast milk jaundice usually starts to show after 7 days of life. It peaks 2 to 3 weeks and can take more than 1 month to clear. It is thought to be caused by insufficient breast milk intake and or breast milk from some mothers who have a substance that slows down hepatic conjugation of bilirubin. Now, my son had bilirubin. I forgot his levels, but they weren't high enough for him to life threatening or whatever. But they did put him, it was high enough for him to have to stay in the hospital for a couple days longer, and they did put him under the light. So physiological jaundice starts after 24 hours and usually clears up within 2 to 3 weeks. So stop it. Let's read the rationale because I like the rationale a little better, because that still does not kind of give you the answer, like help you with the answer. Like just reading that, I still probably, well, when I answered the first time, I got it wrong. So let's read the rationale and it'll make more sense. 163. Let's see. 163. Phototherapy is usually indicated for these infants, which is false. And it's when you read about it, it says that it usually clears up in 2 to 3 weeks. It doesn't say no treatment is necessary, no photolight is necessary. It doesn't say that. So just reading this. But then again, the Leik's book is just kind of like a review of the more mother fudge cake. He got my lip gloss. Aiden. What is wrong with you? Give me that. Give me this. What's wrong with you? This is my good stuff. Hands. Yeah, your hands nasty now. This is my Rihanna. You got it all over your face. What is? No. Show my buddies. Show my friends your face. This is what he do with my Rihanna lip gloss. All on his hands. All on his face. Look at your face, Aiden. You see your greasy face? That's lip gloss. No. Get over here. Let's wipe your face and your hands. Get this off your face. It's all thick. Do you notice you make me come out of my video every session? Get your stinking booty on. Give me my lip gloss. No. Your little stink booty. No. Sorry about that. Oh Lord, it's my good lip gloss too. All right. Now where were we? I want to look at the rationale. Uh, okay. Phototherapy is usually indicated for these infants, which is false. The majority of infants with physiological jaundice do not need phototherapy. This form of jaundice is caused by a buildup of hold on, cold water. Okay, hold on, honey. Okay, this form of jaundice is caused by a buildup of unconjugated bilirubin because because the infant's immature liver cannot metabolize and excrete it quickly enough. So they don't need phototherapy for physiological jaundice. Remember that for the test, guys. All right, so moving on. Let's see. Oh, another phototherapy one. All of the following statements about phototherapy are correct except A, are correct except. So we're looking for what is false again. So here we go. All of the following statements about phototherapy are correct except A, light from the blue to white spectrum is used. This is phototherapy, not physiological jaundice. Okay, this is about phototherapy. All of the statements about phototherapy are correct except the yeah, it's still some on you because it's thick. So I have to wash your whole face. You have to get in the probably. Okay, here we go. I thought I wouldn't have to go through this week, but who am I to think that? Why would I think that? Okay. Hey, Aiden, where's your iPad, honey? Did your iPad die? Go get your iPad. Please, iPad, don't be dead. Okay. All of the following statements about phototherapy are correct except A, light from the blue to white spectrum is used. B, it is not always necessary to use a shield for the infant's eyes. C, unconjugated bilirubin in the skin is converted to a water soluble non-toxic substance that is excreted in the bile. The infant's eyes should be shielded. Okay. So here we go. Let's break this down and talk about this. And you guys can type your answer in the box if you in the chat box if you want to. But I'm going to give what I think is the answer because I don't know the answer. I think I know the answer, but I'm not sure. So you say B, okay. Light from the blue to white spectrum is used. Okay. It is not always necessary to use a shield for the infant's eye. Yeah. So this could trick you up because in the past we've been taught that always and never isn't the correct answers. I understand that this is not saying that the infant's eye should always be shielded or whatnot, but that is true. So B says it is not always necessary to use a shield for the infant's eye. That's false. I know that from past studying that, and from my own son and being in the hospital and talking about it, and like I said, researching it when he had it. You have to cover the child's eye. Um, the rationale behind it, I don't know it, but I should know it. But let's see if let's read it. Let's see. Let's see if it talks about it. Um, I'm looking on page 408 where it talks about jaundice, and it doesn't say. It says, like, I'll just read it. Bilirubin break down products from old red blood cells, binds to the brain and the nerves, neurotoxic. If elevation is due to increased breakdown of fetal red blood cells combined with exceeding the infant's liver capacity to conjugate the bilirubin. So too much is breaking down, and a little tiny infant's little tiny liver it's breaking down too much. Where the little tiny liver, like, hey, this is too much. I can't break this down. Blah blah blah. So we get bilirubin. Anyway, so the treatment plan, check the bilirubin level. Use non-invasive methods first. So bilirubinometers. If suspected, pathological jaundice, order serum fractionated bilirubin level, Combs test, CBC, reticulocyte count, peripheral smear. Treatment. Treatment is usually not needed. Oh, keep baby well hydrated with breast milk or formula. Feed infant every 2 to 3 hours, 10 to 12 times per day. First line treatment is phototherapy. Light used in the blue spectrum is the most effective wavelength. The skin converts bilirubin into a non toxic, water soluble form so that it is excreted in the urine. All newborns should be seen for a follow up within the first 5 days of life to check for jaundice. So, no complication of bilirubin is kernicterus. It's a neurological disorder caused by high levels of unbound bilirubin in the circulation that damages the infant's central nervous system, associated with severe mental retardation and seizures. So let's read the rationale because I just like the rationale because it really didn't say anything about eyes. So let's see the rationale, and it should say something about eyes, which is 170. And I'll repeat those. If it's somebody else other than you in here, Miss Impressed, then I'll repeat the P's questions that I got out the end. 170. 170, page 653. And the answer is D. The patient needs to be, wait a minute. Oh, 170. The answer is B. It is not always necessary to use a shield for the infant's eyes. When using phototherapy, the eye should always be protected by using a shield or goggle to prevent eye damage. And I just have to look it up. So, how does photo therapy? How does phototherapy cause eye damage? It is a safe and easily available treatment worldwide, and the side effects are not serious. The short term, what is this? Oh, the short term side effects of phototherapy includes interface with maternal infant interaction, imbalance of the thermal environment and water loss, electrolytes disturbance, bronze baby syndrome, and uh, circadian rhythm disorder. So, can it? We know about the eyes. In adults, prolonged exposure to blue lights, we're not talking about kids, although retinal damage from phototherapy has not been reported. Okay. Although retinal damage from phototherapy, and what I'm reading is from Stanford Medical edu dot edu, facts about phototherapy in newborn nursery, Stanford Medicine. Although retinal damage from phototherapy has not been reported, eye covers for newborns are a standard prophylaxis. So it hasn't been reported or anything, but it's just a prophylaxis to cover the eyes at all times. Okay. You got the socks off? Good job. What's wrong with your iPad? Is it dead? Okay, one. Here we go. The next question. 6. Question number 6. All of the following children are within the parameters of normal growth and development for their age group, except, so which one of these is wrong? False. All of the following children are within parameters of normal growth and development for their age group, except A, a 2-month-old who coos and smiles. B, a 14-month-old who understands complex commands. C, a 20-month-old who can walk without support. D, a 3-year-old who can speak in 3 to 4 word sentences. All of the following children are within the parameters of normal growth and development for their age group, except B. Right. I'll choose B too. Like a 14-month-old, like that's like 12 months is 1. So a 1-year-old, a 14-month is not about to understand no complex commands. My 3-year-old, Aiden, barely understands. Okay. Drink some water. Complex demands. Okay, here we go. See here. And then the growth and development is on page, starts on page 404 to 405 or to 406. Does it carry over to 406? Yes, it does. So we talked, the question included a 2-month-old. So a 2-month-old should be able to follow objects past midline, coos, vials, and makes gurgling sounds, lifts head up 45 degrees when in a prone position, and smiles in response to another. Okay. So it says a 2-month-old who can coos and smiles within normal parameters. B, a 14-month-old who understands complex commands. 14 months. Let's see. They doing it 14 months. They ain't, no. Okay. They don't even have 14 months on here. First of all, they have 12 months, fine motor, can use a sippy cup, gross motor, stands independently, may walk independently and starts to cruise. So for the 12-month, they didn't even say that's 30 months. So for the 15 months, since they don't even have 14, feed self with a spoon, can drink from a cup. So up to 18 months, they're not even saying that they can understand complex commands. So let's read the rationale. 173. The answer is B, a 14-month-old who understands complex commands. A 14-month-old child should developmentally be able to say mama and dada, knows his own name, and knows at least 2 to 4 words. A 2-year-old is able to understand simple commands. So yeah, girl, we got that right, Miss Impress. Hey, put that down before you bust my fireplace. Put that down. Come over here with that. Get away from the fireplace with that. Thank you. All right. So that was 174. So 170. Let's see. We did 173. So this is the 7th question. You are reviewing the bilirubin level of a 3-day-old full-term neonate. You note that it is 10 milligram a deciliter. The infant has a slight yellow color to his skin, mucous membranes, and sclera. The infant is feeding well, is not irritable, and has 8 to 10 wet diapers per day. Which of the following is a true statement? True. A, keep monitoring the infant's bilirubin level until it returns to normal in about 1 week. B, recommend that the infant be treated with phototherapy 10 minutes a day until bilirubin levels is back to normal range. C, refer the infant to a neonatologist as soon as possible. D, refer the infant to a neonatal intensive care unit. How old? 3 day old, full term. So we read this one. So I'll read it again. You are reviewing the bilirubin level of a 3-day-old full-term neonate. Note that it is 10 milligrams per deciliter. The infant has a slight yellow color to his skin, mucous membranes, and sclera. The infant is feeding well, is not irritable, and has 8 to 10 wet diapers a day. Which of the following is a true statement for the 3-day-old full-term neonate with a bilirubin level of 10 milligrams per deciliter? Keep monitoring the infant's bilirubin until it returns to normal in about 1 week. B, recommend that the infant be treated with phototherapy 10 minutes a day until the bilirubin level is back to normal range. C, refer the infant to a neonatologist as soon as possible. D, refer the infant to a neonatal intensive care unit. So let's think about this for a minute. So I believe they said high levels is 13 to 15 milligrams a deciliter. And they will start turning color yellow as early as 5 milligrams per deciliter. So, in my opinion, 10 milligrams is per deciliter is not high enough to one, refer the infant to a neonatologist as soon as possible, which is C, and D, refer the infant to a neonatal intensive care unit because it's not that high. Um, Recommend that the infant be treated with phototherapy. I wouldn't think that was the answer either because it should go away simultaneously is what we read. But let's see. Let's make sure that this is we know what we're talking about. So jaundice of a full-term infant after 2 weeks of age. Bilirubin levels increase rapidly, greater than 0.2 milligrams a deciliter per hour, or is too high. Total bilirubin level greater than 13 to 15 milligrams per deciliter. So, when a bilirubin level is 5 milligrams per deciliter or higher, that's just when the yellow appears. So, in African Americans and Caucasians, the bilirubin can be 7 to 9. But in Asian infants, they have a higher peak level of 10 to 14. So maybe this is an Asian kid, but they didn't really infant and they didn't specify that. But we do know that at 13, that's when we start to put them under a light or whatnot. So let's see what the rationale says. Let's see. Keep the answers is A, correct. Keep monitoring the infant's bilirubin level until it returns to normal in about a week. Bilirubin is excreted through the urine and feces. Increased fluids and wetting 8 to 10 diapers a day is sufficient fluid intake excretion to help bring down the bilirubin level. Levels should continue to be monitored and should improve in approximately 1 week. So that was another thing. The baby's eating good, the baby's wetting, like the bilirubin is coming out through the urine. She was wetting 8 to 10 diapers or whatnot. So it's bound to go down. So that's good. So number 8. Number 8. Number 8. You love numbers, don't you? Number 8. Number 2. Number 3. Number what? 2. Give me a kiss. All right. So here we go. A mother is breastfeeding her full-term 4-year-old infant. She wants to know whether she should give the infant vitamin supplements. The best advice is A, because she is breastfeeding, the infant does not need any vitamins. B, breast milk gives the infant all the vitamins he needs until 12 months of age. C, breastfed infants require vitamin D supplementation beginning in the first days of life. D, infant formula can be used to supplement breastfeeding as needed. So, what do you think, Miss Impress? A newborn mother is breastfeeding her full-term 4-week-old infant. She wants to know whether she should give the infant vitamin supplements. The best advice is C. Breastfed infants require vitamin D supplementation beginning in the first few days of life. Correct. And that's the same answer that I would give. And I know that because I am a breastfeeding mother. And the child also needs iron because you don't get iron in breast milk. You do get that in fortified milk. Hey, come out of there. Don't turn that water on at all. Do not turn that water on. If you close the door, I still can hear. If you turn the water on, do not turn the water on because I can hear. Do not turn the water on. Breastfeeding. Give vitamin D drops 400 IU of vitamin D starting in the first few days of life if breastfeeding, because breast milk alone does not provide adequate levels of vitamin D. Infant formula is supplemented with vitamin D, iron, and other vitamins and essential fatty acids. Breast milk or formula contains 20 calories per ounce, decreases risk of infection to include otitis media during the first few weeks of life. So, you were right. It's C. So, breastfed infants require vitamin D supplementation beginning in the first few days of life. And that is on page 399. And the rationale, let's see. 197. See, breastfed infants require vitamin D supplementation beginning the first few days of life. The American Academy of Pediatrics 2010 recommends vitamin D 400 IU a day supplementation starting the first few days of life for all breastfed infants to decrease the risk of rickets. It can be given as part of a multivitamin, infant supplementation, or in a vitamin D supplementation. Both are over the counter. Breast milk alone does not provide infants with adequate intake of vitamin D. And I always look up even though I have rickets, even though I have, I think I know, but I want to make sure. And then I like to look up stuff in a study group that, so it says it can cause rickets. Well, we need to know what rickets is. Osteomalacia. Vitamin D promotes the body's absorption of calcium and phosphorus. Extreme or prolonged lack of vitamin D makes it difficult to maintain proper calcium and phosphorus levels in bones, which would can cause rickets. Symptoms include delayed growth, bow leg, weakness, pain in the spine, pelvis, and legs. People may experience in the bones, pain in the bones, cramping, flaccid muscles, or muscle weakness. Also common acquired deformity of the chest and rib, bone fracture, bow legs, cavity deformity of the skull, or slow growth. Rickets, delay in motor skills. Okay. We don't want rickets. And you better start taking your vitamins now. Aiden don't like to take his vitamins. You can have rickets if you don't have enough vitamin D and calcium and phosphorus. All right, so that's that. So the answer was C. Okay. Question number 9. Number 9. Question number 9. Number 9. Which of the following foods would you advise a new mother to introduce? That's why don't nobody join our study groups. Okay, which of the following foods would you advise a new mother to introduce to her 6-month-old infant? 6-month-old infant. Now let's take out what the old school grandmas and mamas be telling us, because they tried to tell me to give my son some meat and stuff at 3-4 months, and I'm like, listen, no, like. So let's get them out of our heads and let's answer the question correctly. Which of the following foods would you advise a new mother to introduce to her 6-month-old infant first? A, iron fortified rice cereal. B, plain rice cereal. C, iron fortified parade chicken meat. D, plain parade carrots. Parade. So I would just simply say, out of iron fortified rice cereal and plain rice cereal, I would just go ahead and give iron fortified rice cereal, because I know the kids need the iron. So why give them plain? And then chickens and meats, I know you're not giving that to a 6-month-old. You said plain parade carrots. You know what? When I first answered this question, I gotta be honest. I did put plain parade carrots, because the pediatrician I work for, he said at 6 months you start introducing a child to vegetables. So let's read it. Here we go. Don't worry. Be happy. Don't worry. Be happy. Okay. Breastfeeding, cow's milk, solid foods. Solid foods on page 399. Solid foods can start at 4 to 6 months. Start with rice cereal fortified with iron before other types of cereal or food. Introduce one food at a time for 4 to 5 days. If allergic, easier to identify the food that they're allergic to. So it is rice cereal fortified with iron. And let's see if the rationale says anything more specific to it. It's 202. Iron fortified cereal. A. At 6 months of age, it is recommended that the infant be fed iron fortified cereal. Introducing only one new food at a time is recommended. In case of allergy, you will be able to identify it. So don't say nothing more. But kids need vitamin D and iron. I do know that. So that's why I picked the fortified rice cereal. After I got it out my head that they start vegetables, like the pediatrician said. But I'm not saying he wrong either. Like, he's been a pediatrician for 40 years, so I don't know. Okay, question number 9. We already did number 9. Question number 10. Question number 10. What is the caloric content of infant formula and breast milk? And I remember reading that when I was reading about vitamin D. I mean breast milk and needing vitamin D. So, what is the caloric content of calorie? In case I'm saying it with an accent wrong or something, but what is the caloric content of infant formula and breast milk? Is it A, 10 kilo? I think it's kilo calories. No, 10 calories. B, 15 calories. C, 20 calories. Or D, 25 calories. So what is the caloric content of infant formula and breast milk? A, 10 kcals per 30 milliliters. B, 15 kcals per 30 milliliters. C, 20 kcals per 30 milliliters. Or D, 25 kcals of 30 milliliters. And I would say that is 20 kcals per 30 milliliters of content of infant formula and breast milk, because I remember reading it. And let's see. On page 399, breast milk or formula contains 20 calories per ounce. Breast milk or formula contains 20 calories per ounce. So I just remember reading that. And let's see the rationale for this one. Just 236. It's probably going to say the same thing. Because what else? It's not too much you can say. Yeah. C, 20 kcals per 30 milliliters. The caloric content of infant formula and breast milk is 20 cals per 30 milliliters. All right, and I have one more. So let's do the last one. And I circled something in here that I want to look at. Okay. The nurse practitioner examines a 4-week. The nurse practitioner examines a 4-week-old boy whose mother reports that he has cried for at least 3 hours a day at a time. 3 hours a day at a time. Since birth. It's 4 weeks. So every day, the 4-week-old infant cries at the same time for 3 hours, at least 3 hours a day. What is the main goal in the clinical evaluation of this infant? A, rule out any physiological cause for the crying spells. B, make sure that the infant is well clothed. C, evaluate the environment. D, order laboratory and diagnostic testing. So here we go one more time, and to give you a chance to answer. The nurse practitioner examines a 4-week-old boy whose mother reports that the infant has cried for at least 3 hours a day at a time, at the same time of the day since birth. What is the main goal in the clinical evaluation of the infant? A, rule out any physiological cause for the crying spells. Ensure that the infant is well clothed. C, evaluate the environment. D, order laboratory and diagnostic testing. What is the main goal? So I would say that the main goal is to being that it happens at the same time every day since birth, and the baby cries for 3 hours, the same time. You need to rule out any physiological cause for the crying. The other one that kind of makes sense is evaluate the environment. But the first thing that I would think is like something is going on at the same time. So let's see what it says in the readings. Okay. Don't you turn that water on. See, evaluate the environment. Okay, let's see. Infant colic rule of threes, page 409. The goal when evaluating an infant with colic is to rule out conditions causing pain and or discomfort, infection, environment, and formula allergy. Crying and irritability lasting a total of 3 hours a day in an infant younger than 3 months. Crying usually occurs around the same day. Crying occurs more than 3 days in a week. Colic usually resolves by 3 to 4 months. So the goal when evaluating an infant with colic is to rule out conditions causing pain and or discomfort, infections, environment, and formula allergy. So I said physiological factors, and then I said environmental makes sense. But the first thing, what's the matter? What? What's the matter? You hurt yourself? Are you okay? Oh, you crying? Oh, don't cry. Don't cry. Don't cry. It's okay. Oh my gosh. It's okay. Ew. Okay. Let's see. So I said physiology. I was thinking the least evasive first, then move on. It's okay. Oh, it's okay. 50. Yeah. It's okay. A, rule out any physiological cause for the crying spells. For infants who cry for several hours during the day, ruling out a physiological problem that may be causing the distress is recommended. So that's all I have for newborns, but I circled something that I wanted to mention. I think it was a reminder. Don't turn that water on. Oh no, that was nothing. Okay, well that's it. So that wraps it up for the freaking study session, and I really enjoyed answering these questions with you, Miss Impress. And thank you for the other person that joined. I don't know who it is because I don't know unless they leave a comment. But that wraps up chapter 20, uh, pediatric review newborns, and 23 adolescent review. I didn't have any questions for adolescent review because I didn't get to that chapter. So what I would do is go over that chapter, adolescents, and then I would answer the questions for the final that I made us or whatnot. And like I said, I went to the back of the book and I just got all the PEDS questions out of the back of the book. And you guys can replay this video to get each question in the back of the book that is a PEDS question for our PEDS final review. So I'm going to do that. I'm going to read the Adolescent, and then I'm going to the Adolescent chapter, and then I'm going to take the final exam that I made up. And it is in the back of this Leik's book. It's 107 questions. Like I said, to prepare for this, the boards, we should be at least answering at this point, if we're studying now. Like I don't graduate until February 22nd. So I should be answering 100 questions a day. A week. Now, when I get close, when it's time to study, like I graduate and it's time to study for the boards, then of course I will probably do 100 questions, 50 to 100 questions a day. So I went in the back of this book and I marked every PEDS question. So in the beginning of this video, you can go back and get a pen and paper. I spoke real fast, but just get a pen and paper and write the numbers down. You can pause the video and in case I'm talking too fast or whatnot, until you're all caught up. We're not nursing. Remember, you're a 3-year-old big boy. 3-year-old big boys don't nurse their mommy. Bye-bye. Say bye-bye. Say bye-bye. No more. Say bye-bye. Say bye-bye. No more nursing. That's why I have to stop, because they get angry and want to fight. So, yeah, I don't feel like doing this whole list all over again. Sorry, that's coffee. But I wrote down every PEDS question in the back of this book. So do the final, answer all the questions, the PEDS questions. And so next week, oh my God, next week, it's time to end this because he is ready. Next week, I'm going to do Women's Health Review, Chapter 17, Women's Health Review, and Women's Chapter 19, Women's Health Pregnancy, and Childbirth Review. So next week, here, drink some water. Drink some cold water. So once again, next week, I'm going to do Women's Health Review, Chapter 17, and Women's Health Pregnancy and Childbirth Review, Chapter 19. That's next week for the study session. And then we'll do Men's Health Review and Sexual Transmitted Diseases, Infections, the following week. So next week, Chapter 17, Women's Health Review. Why'd you put that in there? And Chapter 19, Women's Health, Pregnancy, and Childbirth Review. You put it in there. And so that's it. And once again, thank you for joining me. And you guys have a good night. And I can't apologize for Aiden getting the video, because I already warned everybody that that's what it's going to be. And this is not a professional page. This is just a nursing student who's been doing this for a while, who can get it done with a kid. And this is what I go through. So if I can do it, you guys can do it. And it's just a real life situation. It's not professional at all, unfortunately. In the future, when I do my podcast, it will be professional. Aiden will not be in the videos, I promise. But as right now, it is what it is. He's been in the video since day one, after I had him in my Excelsior video studying. But yeah, we gonna be good. So That's good if you, like I said, if you guys are getting an early start with this, just like me. And that's good if you're prepping for the boards and um, you're joining me. So, good night, and thanks again for joining me. Bye.